afternoon, and thank you for joining us for today's National Conference of State Legislatures Public Health Webinar Series. Our webinar today is titled Pharmacists' Role in Public Health, Increasing Access to Care. My name is Sydney Enland, and I am a policy specialist in NCSL's health program, and I will be your moderator today. Before I introduce our speakers, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions and answer any questions in the chat box on your screen. And to begin building some comfortability with the chat function, and to also learn who is on the line today, I invite you to type in the state from which you are calling from. We will hold a formal Q&A after our presenters are finished presenting. I want to briefly mention the resources we have available. Above the presentation, you will see a couple tabs with one of them labeled resources. Here you can find and download a PDF version of the PowerPoint, as well as some other handouts. Another tab is labeled Speaker, where you can read the bio of today's speakers. The webinar platform we are using is optimized for use in Google Chrome. While other web browsers such as Firefox may work, we recommend anyone experiencing technical difficulties try signing in through Chrome instead. If you continue to experience technical issues, please email registration@ncsl.org, where our team is ready to assist you. Today's webinar is being recorded and will be available on NCSL's website within the week. I would also like to thank the Health Resources and Services Administration for their support of this webinar. So here is our agenda for today. And our experts joining us for a national overview, we have Emily Hawes, an associate professor of clinical education at the University of North Carolina Eshelman School of Pharmacy. We have Stephanie Ferrari, who is the chair of the University of North Carolina Eshelman School of Pharmacy Division of Practice Advancement and Clinical Education. And we have two speakers for our state section, Senator Elizabeth Steiner Hayward from Oregon and Senator Evan Vickers from Utah. So we're here today to talk about how states can and are utilizing pharmacists to increase access to care, especially in rural and underserved areas. The increased need for medical care and prescription drugs, coupled with the scarcity of primary care physicians in rural areas, exacerbates many barriers to accessing necessary healthcare. Maximizing the use of pharmacists as part of the healthcare delivery system is among several state strategies to meet the unique healthcare needs of rural and underserved communities. With nearly 9 in 10 Americans living within 5 miles of a community pharmacy, pharmacists are some of the most accessible healthcare professionals. Pharmacists are trained to test, treat, and immunize for many infectious diseases, including influenza, and by practicing their full scope of practice within their training and license, could alleviate pressure on the healthcare system created by the COVID-19 pandemic. Along with dispensing prescription medications and offering expertise in the safe use of prescriptions to patients, pharmacists play an important role in enhancing public health and increasing access to care in those rural and underserved areas in coordination with other healthcare providers. Now let's move into the presentation by our experts. First up, we have Emily Hawes and Stephanie Ferrari. Emily is a clinical pharmacist practitioner caring for patients in a family medicine clinic in rural North Carolina. She is actively involved in research and teaching through her faculty positions at the UNC School of Medicine Department of Family Medicine and UNC Eshelman School of Pharmacy. Stephanie Ferrari is the chair of the Practice Advancement and Clinical Education Division at the UNC Eshelman School of Pharmacy. Her main research interests include advancing clinical practice in the community pharmacy setting, medication optimization, and integrating community pharmacists into team-based care. Emily and Stephanie, thank you so much for joining us today. The floor is now yours.
Thank you so much, Sydney. My name is Emily Hawes, faculty at the UNC School of Medicine and Eshelman School of Pharmacy, and I'm joined today by my colleague, Dr. Stephanie Ferreri, a distinguished professor and chair at the UNC Eshelman School of Pharmacy. We are thrilled to share with you how pharmacists are playing an important role in public health by increasing access to essential care in the U.S. To start us off, I'd like to share a story. I'm a pharmacist practicing, like Sydney said, in primary care office in rural Western North Carolina. I'm integrated into a primary care team, and because of the expanded care privileges like prescribing that I have through our state's legislation, I'm able to directly ensure that patients in our clinic are on the safest, most affordable, most effective, and simplest possible drug regimens. This past year, I cared for a patient who was referred to me by one of our primary care providers for a hospital follow-up visit and ongoing chronic care management. Through an initial behavioral health assessment, it was clear that his major depression was not adequately treated, and he was fatigued, weak, and almost white when I first met him. His blood levels were consistent with inadequately treated anemia. His drug list was 20 medications long, and his numerous chronic conditions were completely out of control. So the first thing I did in light of this daunting list of needs and things to do was to focus on two things: depression and anemia. I started him on an antidepressant and plugged him in to see our clinic's therapist. I counseled him on the importance of why he needed to take his iron and how to take it best. Over the next few months, his blood count started to normalize and his motivation to care for his health began improving. Through our visits, I learned that he was not able to afford his medications, which was contributing to non-adherence. To address this, I referred him to an insurance counselor through a free state program that helped him switch to a better Medicare Part D plan. Then I worked with his community pharmacist and through a stepwise approach, in collaboration with his primary care provider, switched him to the most affordable options for each of his conditions. For example, I changed his insulin from a more cumbersome, expensive 4-shot regimen to a simpler, more affordable 2-shot regimen. I implemented a heart failure action plan to guide him on when and how to take his water pill based on his daily weights. I stopped his high-risk medications that could increase the risk for falls and ordered the recommended vaccinations and screenings. I saw the patient 2 weeks ago in our primary care office, and he can now afford his medication, and thankfully he's taking them. His diabetes is right where we want it to be. He went from having 3 heart failure-related hospitalizations the year prior to none thus far this year. He went from 2 falls the year prior to no falls this year. Bottom line, he's healthier, and he'll tell you he's happier. This is one of many stories that Stephanie and I can share along with pharmacists across the nation. And today, we hope to leave you with a greater understanding of the training and preparedness of the profession, as well as an awareness of ways that pharmacists are functioning beyond the traditional dispensatory roles. We will also cover challenges that limit access to these types of services, and Stephanie will highlight potential opportunities and steps that you can take to help assure equitable access to the residents of your state. So to give you a little bit more of a background, pharmacists, like Sydney mentioned, are among the nation's most accessible healthcare professionals, with most Americans living within 5 miles of a community pharmacy. The workforce is large, with over 380,000 pharmacists in the U.S., and that number is only anticipated to increase by 2030. The figure you see on the slide shows the distribution of work locations of pharmacists. Over half of pharmacists work in retail and community settings, a quarter in hospitals and other healthcare facilities, and the remaining 17% in a variety of locations, including academia, pharmaceutical wholesalers, federal agencies like the FDA or Indian Health Services, and VA. So not only are the settings where pharmacists practice diverse, but the location of pharmacists is widespread. This map on the slide shows the number of pharmacists per 100,000 population in each state. The entry-level degree for pharmacists is the Doctor of Pharmacy, which is a 4-year professional degree. To become licensed pharmacists, PharmD graduates must complete the NAPLEX, a national test of pharmacy skills and knowledge, as well as a state-specific pharmacy law exam. Pharmacists may also choose to complete residency or fellowship training in different specialties, such as cardiology, infectious diseases, oncology, and even pediatrics. And the number choosing this type of training is increasing each year. There are also several certifications in specific knowledge areas, like deciding to become a certified diabetes educator. Pharmacists are being well trained and are ready to step into roles that allow them to practice at the top of their license to meaningfully impact public health. So why are pharmacists needed? More than half of Americans have at least one chronic condition. And of those people with chronic diseases, 50 to 75% are non-adherent to treatment. And that non-adherence, unfortunately, has been shown to result in $100 billion each year in excess hospitalizations. Furthermore, over $500 billion is spent on the misuse, underuse, and overuse of medications annually. There's clearly a need for help with medications, which presents a unique opportunity for pharmacists, the medication experts, to address this public health problem by optimizing medication use that has been shown to improve quality of care as well as reduce healthcare costs. Pharmacists across settings are functioning in many of these expanded roles, and we want to highlight 3 ways today. They're ensuring access to essential medications and therapies, like starting needed drugs or devices, eliminating barriers to get patients high-cost medications like oral chemotherapy. Next, delivering services to improve medication use. For example, educating a patient leaving the hospital about how to take their medications, or ordering lab tests and adjusting a dose based on the results. Stopping a drug that is unsafe due to a drug interaction. Third, pharmacists are promoting health and overall wellness through activities like conducting health screenings at the local pharmacy, wellness visits, and counseling on healthy lifestyles. The extent by which pharmacists can function in some of these roles we've mentioned is significantly impacted by scope of practice laws. Fortunately, U.S. states are increasingly recognizing the value of authorizing pharmacists to perform these functions, such as prescribing, in order to increase access to important medications. Each state's laws vary, and this prescriptive authority exists somewhere along a continuum, as you can see pictured on the slide. On the left side of the continuum, we see a more restrictive authority, where prescribing is delegated through a collaborative practice agreement with a certain pharmacist and a certain provider or group of providers who are responsible for diagnosing and supervising the pharmacist's care. All the way to the right of the continuum, a more independent functionality, where prescribing authority comes directly from the state, whether the pharmacy board or the state's physician general. To illustrate this continuum further, let's look at 4 states' examples. Maine's on the left, Maine's Collaborative Practice Agreement statute allows a pharmacist to order and evaluate the results of labs, initiate, monitor, modify, and discontinue drug therapy for a particular patient pursuant to the Collaborative Practice Agreement with a practitioner who's treating the patient. So you can see that patient-specific agreement. In Vermont, we see an example of a population-specific collaborative practice agreement, where a pharmacist may perform certain patient care functions under a protocol of specified conditions, like hepatitis C or patients with HIV or asthma, in collaboration with a practitioner or practitioners. Shifting to more autonomous prescribing, in New York, for example, there is a statewide prescribing protocol that allows New York licensed pharmacists to determine patients at risk for opioid overdose and then subsequently dispense naloxone, the opioid reversal agent. Idaho on the far right is even less restrictive, where the board broadly allows pharmacists prescribing of drugs and devices, with a few exceptions, for conditions not requiring a new diagnosis, those that are mild or self-limiting, or diagnoses that are easily identified by a test, like a strep test. The authority for expanded functionalities is particularly important for managing chronic conditions, some of which are listed on this slide. In clinics, retail locations, and hospitals, pharmacists are relied on for doing this. And although this is certainly needed in urban settings, there is an even greater need in rural and underserved America, especially because of the maldistribution of primary care physicians and other specialists in these communities. Our rural mountain town does not have an endocrinologist, and understandably, patients don't want to travel over 40 miles one way for frequent diabetes visits. So I am one of the few, if not the only, healthcare professional in our area comfortable with managing insulin pumps or complicated insulin regimens. But unfortunately, scope of practice laws limit my ability to help all the patients of the community, which our physicians and local residents are specifically asking for. I'm going to leave you with one last story before handing over to Stephanie. I was conducting a telehealth visit on Friday, and we were wrapping up the session, and the patient said, Emily, my husband's on a lot of medications started by different specialists. I think he may be experiencing a side effect. He recently had a fall. Can you review his medications and change them like you did for me today? Because her husband has a primary care doctor in a different practice, I sadly had to say no. Today, we are giving you a small snapshot of ways that pharmacists are helping, like addressing the disease burden of a growing aging population, and sharing with you about barriers limiting your population from receiving these services. And now I'll turn it over to Stephanie to cover additional pharmacist capabilities.
Thank you, Emily, and thank you for having me here today. I just wanted to expand upon some of the scope of practice across the United States. Emily shared with you some stories related to chronic disease state management and diabetes in particular. Well, I'm going to share 4 more examples with you. The first one being naloxone access in community pharmacies. She already shared with you that naloxone is the reversal agent for patients that might unintentionally or intentionally take an opioid. And since states have granted pharmacists direct authority to dispense naloxone, we have seen a decrease in overdose deaths by 34%. In July of 2015, only 3 states had policies that allowed pharmacists to dispense this opioid antagonist. Now all states, you can see according to this map, have some sort of authority for ensuring access. However, when you look at this map, you will also see that there's lots of different colors. The green is the least restrictive. If you live in one of those states that is dark green, your pharmacist can dispense naloxone to anyone that walks into a pharmacy that is able to distribute naloxone. As we get down the continuum to the yellow or the peach or the red, it's more restrictive. Again, according to that continuum, you have to do it by a protocol or patient-specific or population-specific. Really, our goal here is to turn this entire United States into dark green so all of our patients have access to naloxone distribution. In addition to naloxone distribution in the opioid crisis, pharmacists are also assisting with deprescribing, which is a term that basically gets patients off of medications that are not appropriate for them. Many times when I talk to my patients, I tell them that I'm doing a medication review to make sure that they're optimizing their medications, that they're taking the right drug, the right time, right dose for them. And I usually tell them my goal is to get them off of medications so that they feel better. And they're always surprised to hear that a pharmacist wants to get them off of their medications, but they always walk away much happier because I'm able to help them with their quality of life and make sure the medications are correct. I just want to share a quick story with you about some research that I am doing in older adults. So those are typically 65 and older. And as we age, our body changes. Our kidneys don't work quite as well. Our liver doesn't quite as well. our body just metabolizes or processes drugs a little bit differently. And this is a population where we need to deprescribe medications for them, because medications can lead to side effects, falls, like Emily mentioned, and opioids are one of those drugs. And so the study that I'm doing, we are actually looking at older adults and deprescribing opioids and deprescribing benzodiazepines, which is another class that helps with sleep and helps with anxiety. But in older adults, it's not an appropriate class. And so there are many other types of medications that are more appropriate for our older adults to be able to have them on these right medicines. However, they don't all have access to a pharmacist. And the prescribers that we're working with can't afford a pharmacist within their office. So the study that we're doing is we're setting up a consultant model where pharmacists in the central part of the state are now delivering services, consultant services, all across the state to be able to get a pharmacist into these primary care offices in rural communities that typically would not have access to a pharmacist, to help make sure that their patients are taking the right drugs and the right doses and they have access to a pharmacist. So that's just one example. Another example where pharmacists are helping with scope of practice is related to the smoking and vaping crisis. I don't have to convince all of you that smoking and vaping is a public health emergency, causing close to 500,000 deaths annually and costing more than $300 billion in each year. But if you look at this slide, only 12 states have statutes or regulations that address pharmacist prescribing of tobacco cessation aids. And a lot of the tobacco cessation or ways that pharmacists can help with tobacco cessation, many products are available over the counter, meaning you do not need a prescription. However, there are several behind the counter, meaning you do need a prescription. And not all states allow pharmacists full access to all the medications that will help their patients ultimately stop smoking or stop vaping. So this is an opportunity for us to be able to expand scope of practice. Another area I'm excited to share is disease prevention through vaccinations. When I first started practicing, this statistic was abysmal. Not all 50 states allowed vaccine administration by pharmacists. I'm proud to say that today, all 50 states do allow vaccine administration by pharmacists, and 1 in 5 of the patients that live in your state probably receive their flu vaccine in a pharmacy, which is fantastic when I think about 15 to 20 years ago where we were. However, there is room to grow. Again, if you look at the continuum and the scope of practice on the table here, all 50 states are represented. But at the top, that is a protocol that is either patient or population driven, where a pharmacist is restricted to the vaccines that they're able to give. So those 4 states have some room to go. But as you go down the continuum, you can see that we have some states that there is no prescriber or prescription needed. It might depend on the patient's age. It might depend on the vaccine needed. But if a patient walks into a pharmacy saying that they are traveling to another country and they need their travel vaccines and they are not sure where to get them because their doctor's office does not do this service, the pharmacy in these states are able to do some of these services. So what a fantastic opportunity when we can travel again for the pharmacist to start administering travel vaccinations or other vaccines that promote health and wellness. This year has been a challenging year, to say the least. However, I will say with COVID, pharmacists have had a fantastic opportunity, and pharmacists have responded to the pandemic this year. I'm going to share a term with many of you that you may not be familiar with, this CLIA-waived testing. So CLIA-waived testing is really just a lab-based test that you can get in an outpatient pharmacy. So in any retail pharmacy, if you apply for a CLIA-waived test, you are now assuring that that lab test that you're doing in that pharmacy assures quality. And so this year, because of COVID, you can see close to 1,900 pharmacies have applied for a CLIA waiver, meaning that they are now offering COVID tests in their pharmacy and providing lab tests in their pharmacy that they didn't afford prior to May 2020. What a fantastic way for pharmacists to step up and respond. I will say that they're beyond COVID. There are other lab tests that pharmacists can do. They can test, I mentioned before, that for kidneys. They can also test for liver function. For any of you or might be familiar with your patients who are taking Coumadin, which is a blood thinner that many patients are on, you have to get a blood thinner test, an INR, to make sure that the medication is working appropriately. That's another CLIA-waived test. Something that I used to do in my practice is I was able to administer a pregnancy test in a community pharmacy, which you'd be like, really? But yes, I would have patients come in, take a pregnancy test. If the test came back negative, why they were there is then I administered a Depo-Provera shot, which is a contraceptive for those patients. And I think you're going to be hearing more about contraception in a little bit. But that's another example of me as a community pharmacist able to have access for those patients to receive their test in a community pharmacy setting. So this is one thing that once COVID goes away, pharmacists don't want CLIA tests to go away. We actually want to expand them. We want to do more lab tests. We want to be more accessible to patients, especially in rural areas. We're also stepping up to the plate for COVID vaccines. I'm getting so many messages regarding how we are going to roll out community pharmacists helping with COVID vaccines. And this is Health and Human Services have lowered the age restriction across all 50 states so that we can now do COVID vaccines. And we're hoping that doesn't go away again after COVID. Emily shared with you stories regarding chronic disease state management and how we can help patients with longitudinal care maintain their quality of life. Shortage management is another area where pharmacists in all settings, whether it's health, inpatient, outpatient, so hospitals or community pharmacies can really help. When you think about earlier this year when we thought hydroxychloroquine was going to be an agent to help treat COVID, there was a lot of hoarding going on, a lot of prescriptions being written. And those patients that really needed that medication for their lupus might not have had access to it. So pharmacists, again, are essential to make sure that we're managing the drug supply chain. And we also mentioned we had 2 stories regarding telehealth. Telehealth prior to COVID was something we were dabbling in, but now it's here to stay, and it's definitely a service that pharmacists can increasingly access the rural clinic. Now, with all of that being said, we've shared some wonderful stories with you today. However, there are still some challenges. We share that continuum regarding scope of practice and how there is variation in practice limits where pharmacists can engage with patients across states. The other thing we have not shared with you is that typically pharmacists are routinely reimbursed based on that medication product. So that Coumadin example I shared with you before, as a pharmacist, my pharmacy gets paid when I dispense that Coumadin. However, I routinely do not get paid to do that INR test to make sure that Coumadin is safe and effective in my patient, for my patient. So reimbursement needs to be realigned with the team-based services that are provided. And pharmacists need, the services are really behind the legislation. So we've shared with you today that pharmacists are, workforce is ready and willing. We just need legislative and payment to catch up with what we're able to do. So the opportunities as you walk away today is really look back at your state and assess the needs in your state where pharmacy services can improve the health and well-being of your citizens. Determine which pharmacy organizations and leader in your state can help you take action for team-based care, making sure that the pharmacist is part of the team to making sure that the medications are being used correctly. And there are successful programs across the country. We only dabbled a little bit in some of those successful programs and shared a couple of examples with you to help you inform your efforts of where you want to start. But if you're not sure where to get started, we do have a resource for you through UNC. The Center for Medication Optimization has a consultation page, which we will share with you in the audience chat that you can put in there and say that you need help with policy and what state you're from and perhaps what needs you have, and we can help connect you with those people moving forward. So feel free to take a picture of this slide in case you don't download it later, and we'd happy to follow up with you. In addition, Emily and I are both available. Feel free to reach out to us. We put our emails on here because we're both passionate about advancing pharmacy practice and making sure pharmacists are part of team-based care to ensure that your patients and your citizens in your state are getting the best care possible. So thank you for your time. And I think we're going to turn it over now to our next presenter.
Wonderful. Thank you, Emily and Stephanie, for that really wonderful overview. Excuse me. Next up, we have Senator Elizabeth Steiner Hayward. She has served as the state senator for Northwest Portland and Beaverton since 2012. She is a Senate co-chair of the Full Ways and Means Committee, which oversees Oregon's state budget. Senator Steiner Hayward also serves on the leadership team of the Oregon Senate Democrats as Deputy Majority Leader. Senator Steiner Hayward, thank you so much for joining us. The floor is now yours.
My pleasure. Sydney, thank you so much for inviting me. And the one thing that Sydney didn't include in that is that I am also a physician. I'm a family physician, and I became involved with organized medicine and doing advocacy to help improve access to high quality, affordable healthcare, which absolutely includes pharmacists as part of the team back, gosh, almost 20 years ago now. And I've then eventually ended up in the legislature 9 years ago. But certainly my perspective as a family physician, believing in team-based medicine, believing in the ability of every member of that team to bring something, a unique skill set, and make a unique contribution to the team and to that patient's overall well-being, informs a lot of how I think about my work in the legislature. Now, Oregon has a long history of having pretty open scope of practice. I used to laugh because I'd be on various listservs for state legislation through the American Academy of Family Physicians, and about every year or two, I'd see someone with their hair on fire because their legislature was considering giving nurse practitioners independent practice without having to have a physician supervising them. And people would say the sky was going to fall. And I used to say, yeah, we've been doing this in Oregon for now almost 30 years and then almost 20 years, and the sky has not fallen. So take a deep breath. And that's the thing, one of the messages I would take home today for you. Oregon's had pharmacist independent dispensing and prescribing and administration of immunizations for certainly as long as I can remember. And it's not just flu shots, which I think we think of as typical, but it's any standard immunization. And in fact, we count on them now as a place for kids to get their routine immunizations, although not the really young ones yet, for adults to get pneumococcal vaccine and shingles vaccine, and then certainly flu, and I would certainly expect COVID, because the more distribution points we have for these really critical, life-saving preventive medications, which is what immunizations are, the better. And we continue to expand that. It used to be that pharmacists could do immunizations down to age 10, and now it's down to age 7. And in the case of a public health emergency, it's down to age 3. Clearly, COVID qualifies as a public health emergency, so I would expect that provision to be taken into consideration once we understand what the plans are for immunizing young children. But in addition to this, about 5 years ago in the 2015 legislative session, we significantly expanded pharmacist prescribing privileges to include all the kinds of travel medications that Dr. Ferrari mentioned, such as the right immunizations, if someone needs typhoid or yellow fever or any of those kinds of things, then they can, well, yellow fever is a little specialized, but that's a separate problem. Any of those standard things, or they need to be updated on their tetanus shot before they go, or they need malaria prophylaxis, or any of the other things that we routinely do as part of travel medicine, they can do that at their pharmacist. And I think the point that I want to emphasize about pharmacist prescribing is these are places people go once, twice, 3 times a week, right? They stop in at their local Rite Aid or CVS, or they go to their local Safeway or Albertsons or whatever your grocery chain is in your area. And they all make, they can get those things done while they're there. I was at Costco back in early September and doing my usual Costco run. And I thought, oh, wait, I can get my flu shot. And I popped into the pharmacy and got my flu shot. And that meant I didn't have to call my doctor. I didn't have to figure out when my doctor was doing flu shot clinics. I didn't have to wait for when they were doing it at work, either at my practice or at the legislature, because nobody was in the Capitol these days. I could just do it at Costco, and now I'm done and I don't have to worry about it. So that kind of convenience and the ability to just pop in with a question, the ability to build a relationship with the pharmacist is an important part of developing the pharmacist even further as a critical part of the healthcare team. So that's a really important feature that I want to have people keep in mind. At the same time that we were doing the travel medicine, we also moved forward with contraceptive prescribing. And that includes both hormonal contraceptives, oral hormonal contraceptives, and injectables. We don't do, obviously, Implanon, which is the little rods that are inserted, because that requires special training. But all of these hormonal contraceptives are pretty standard and can be safely prescribed with screening questionnaires and blood pressure checks and followed up. And the more we give women access to contraception, the fewer unintended pregnancies there'll be, the better women's educational attainment will be, the more likely we are to bring women out of poverty. All of these things that are so important, and it all starts with being able to access reproductive health care like contraceptives in an easy way at a place where women go all the time, which is the grocery store. So that's a really important thing. And these services have been taken up by pharmacists across our entire state robustly. And on the next slide, can I do it? Yes, okay. I gave you some resources here, and if you download the slides, you can have all these, but these are links to all of the protocols for immunizations, for contraceptives. We now have naloxone also. We also have emergency insulin, which is really important because the last thing you want is an insulin-dependent diabetic going without their insulin for some reason for even 12 hours, let alone the time that it might take a doctor's office to call in a refill. So emergency insulin and travel. And we're always looking for ways to expand the capabilities of every member of the healthcare team in Oregon. And that's really important because, as both Dr. Hawes and Dr. Ferrari mentioned, pharmacists are everywhere, right? And they are on the front lines of healthcare provision. So I'm very proud that Oregon has recognized the capabilities of pharmacists in the outpatient setting. And obviously we use them in the inpatient and in the clinic setting as well. I'm fortunate, I work at the medical school, and we always have pharmacists surrounding with our inpatient teams, with the family medicine inpatient teams. We have pharmacists who do medication consultations in our clinics, just as Dr. Hawes was describing. And it is invaluable. It is absolutely invaluable because deprescribing is important. Tailoring it to reduce side effects is important. Doing as much as you can to make medications affordable is critically important. So all of these things make an enormous difference to healthcare access and affordability for our patients. I want to close by saying that I completely agree. COVID has changed a lot. And one of the things that I think has changed for the better is the increased use of telehealth services. And I too hope and expect that we'll be able to continue that over the future, regardless of where we are, hopefully out of this pandemic in the not too distant future, because everybody likes it and it hasn't harmed healthcare. And people aren't having problems that are with avoidable illnesses or anything. They're having good control of their high blood pressure, their diabetes, of their heart failure. They're being able to check in about a new diet regimen or side effects of a medication that they started or any of those kinds of things in ways that they couldn't do before. And it's so convenient for everybody. I think all of you have probably had the experience of needing to go to the doctor and you have an appointment at 10 o'clock in the morning, which means you have to say to your work, okay, I'm coming in an hour early at 8. I'm going to work from 8 to 9, and then I'm going to drive to the doctor. And then I'm going to go on to come, and then the doctor's going to be running late, so I'll probably be back after lunch for a 15-minute visit. That's ridiculous. But with telehealth, as long as they can find someplace private at their office to have a conversation so that their privacy is protected, they can be pinged when the doctor's ready to see them and go in and do that consultation and be in and out in the 15 minutes. And more of that 15 minutes is spent with the doctor than with ancillary staff. So the same is true for pharmacists. As they expand their scope of practice, we have to include them in reimbursement protocols, and so that we can reimburse them for managing warfarin, Coumadin, the anticoagulant that Dr. Ferrari mentioned, or for managing contraception. Now, we do provide for a fee, and insurance is required to cover it for contraceptive prescribing and travel medicine. Not so much for immunizations and naloxone and emergency insulin, but for travel and contraception, where they really have to have a consultative role, we do allow them to bill for that separately, and we do require insurance to cover it because we want to be sure that people have access to it. And one of the ways to ensure that is to make sure that it's paid for. So I'm going to close there, and I look forward to answering questions. But I would say that overall, Oregon's experience has been extremely positive. And I personally, as a physician, look forward to expanding the role of pharmacists as part of the healthcare team.
Wonderful. Thank you, Senator Steiner, Hayward. Next up, we have Senator Evan Vickers, who, oh my gosh, excuse me. He is the majority leader in the Utah State Senate, and he served in the Senate since 2013 and represents Beaver, Iron, and Washington counties. He received a degree in pharmacy from the University of Utah and is a pharmacist and small business owner by profession. His work and business leadership has won him the Pharmacist of the Year award from the Utah Pharmacists Association. Senator Vickers, thank you so much for joining us today, and the floor is now yours.
Thank you, Sydney. Appreciate that. It's really been interesting for me to listen to the presentation so far. Being a pharmacist, and just so you know, my family and I own 3 pharmacies, retail pharmacies in southern Utah. I have 2 children. I have 5 children total, and they've all worked in our pharmacies, but 2 of them are pharmacists and work in our businesses as well. So, and each pharmacy is unique in its practice setting, and it's been very interesting. I've served in the legislature for 12 years. I started in the House, and I spent 4 years there and then moved to the Senate. And the last 2 years, well, and I was just reelected to serve as the Senate Majority Leader, so I appreciate that. And appreciate all the, the work that has gone into this presentation and the information. In the state of Utah, we've really, as I was listening to the presentation at where states are at, and that we're kind of in the middle. I would think that, as far as access and availability and utilizing pharmacies and pharmacists, we've done a really good job in some areas, and there's some areas that we still need some work on. But it's been a delicate balance, and Senator Hayward, I'm sure, understands this, and she mentioned it, that sometimes there are these turf battles created, and for years, for example, Utah did not allow physicians to dispense at all. Kind of kept a few gentlemen's agreement, I guess you might say. Physicians prescribe and pharmacists dispense. But we've kind of broken down some of those barriers in the last few years and have availability on both sides. And you have to be a little careful on both sides, I think, from a professional standpoint, to make sure that you're staying within the scope of practice of that profession. And so those are things that you want to consider as you move forward with any kind of legislation in those areas. For example, on the physician dispensing side, we wanted to make sure that we maintain that integrity of the counseling and the interaction with the patient, monitoring interactions and those types of things. And at the same token, physicians are wanting to make sure as pharmacists start to be allowed to prescribe and implement and administer certain types of medications and vaccines that we have our role is covered as well. So in the state of Utah, we've done a lot with collaborative practice agreements, immunizations. We do most of the major immunizations in the state. And Senator Hayward mentioned what Oregon is doing. Utah does very similar to that. The one thing we found this year, and it's very unique, is that we needed to be a little proactive with COVID. As COVID was being rolled out as far as testing and then eventually vaccines, we had to do some proactive work with our Pharmacy Practice Act, and we were able to do that. Actually, we were able to do that through rule without having to involve statute change, but there was some tweaking that needed to be done. And so that's something as a state legislator, if you're looking at that, you may want to make sure you coordinate with your state pharmacy board and state medical board to make sure that you can have adequate access to these programs. One of our pharmacies is CLIA certified and is doing the testing, and we're actually doing the rapid testing right now. And it's amazing how well that's gone. You know, I have to compliment the pharmacist that we have that's managing that store and how well they've done to set up the protocols to keep both his staff safe and the patients safe. And, you know, they're doing 70 or 80 tests a day, you know, in that one store. And so it's interesting, not a lot of pharmacies here have taken the opportunity to do that. Even though there's some CLIA certifications out there, they haven't taken the step forward to do the rapid test. We're seeing more, but it's still been not that many. For example, for quite a while, we were the only one in southern Utah. There are a couple now in St. George, which is a little bigger community, 45 minutes south of us, that are doing it. We're prepared to be able to administer the COVID immunization. The challenge there is, at least right now with the Pfizer vaccine, is the storage requirements on the extreme cold. The Moderna vaccine will be a little bit easier to handle in pharmacies, but so that's a barrier that we're still working through and trying to figure out. Pharmacists have been allowed to administer long-acting injectable drug therapies, aripiprazole and risperidone and olanzapine. We've had a statewide collaborative practice agreement on naloxone, which was mentioned earlier in the presentation, for some time. We do that by having the physician who is with the Department of Health write that order, and then any pharmacy can dispense that medication to, it can be a patient, it can be a caregiver, it could even be just a friend that is concerned about a patient. If in the estimation of the pharmacist that there is a need for that individual to have naloxone to try to save someone's life, then it can be prescribed and dispensed at the pharmacy. A couple of years ago, one of our senators followed Oregon's lead on birth control. And so right now, we're just doing the oral birth control, but we did expand the collaborative practice and the scope of practice for pharmacists to be able to do prescribe and dispense birth controls in their pharmacy. Of course, there's protocols, and quite frankly, Oregon did a really nice job. We followed their law, and we appreciate them taking the lead on that. Interesting, in Utah, we do have medical cannabis, and I know a lot of states do. We have followed a model similar to Connecticut and some of the other states, Minnesota, that have used pharmacists in those cannabis pharmacies. We do not just have dispensaries. We felt like that if it's medicine, we need to treat it like medicine, both from the regulatory standpoint and from the medical side. So our goal was to have that medication be handled from top to bottom, start to finish, with a patient where a medical professional is helping them. And so as our physicians who need to become a qualified medical provider to be able to recommend that medication, they are relying heavily on the pharmacists that are working in these cannabis pharmacies. The pharmacists are actually quickly becoming the experts in the medical cannabis field in the state of Utah. Pharmacy's been a wonderful profession for me. I remember, so right at the first of the presentation, I think Emily mentioned that the entrance degree is a doctor in pharmacy. Well, I'm one of those old guys that graduated under the RPH role. So my degree is a 5-year bachelor. Obviously, the new entry level is a PharmD, and that's what my 2 children have. It's interesting also to watch the progression of the profession over that time period. In my time when I come out of school, you really have 2 choices. You could go to a retail pharmacy or you could go to a hospital pharmacy. Now there's so many other utilizations for pharmacists, and the training is so broad and diverse. You can specialize, as was mentioned, you do residencies, lots of consultation, lots of consult type work, not just the dispensing of prescriptions. In our pharmacies, one of them is a compounding pharmacy. One of them works with 340B, and one of them is the CLIA certified, and so they do a lot with immunization. So each one of those settings has their unique aspects to it, and we're able to kind of specialize in our own little areas, even in a rural independent pharmacy. It's been a great profession. It's certainly opened many, many doors for me. It's been wonderful to work with the other healthcare professionals in our state and in other states. And the nice thing is that we've got a few healthcare professionals in our state. I'm kind of in a bad spot this year after this election cycle. I'm the only healthcare provider in the Senate, which I can tell you from experience already is not a very good place to be. We do have a few physicians in the House, and so there's a few of us on the Hill that are healthcare providers, but it's kind of limited. So when we end up being kind of forced into being experts in a lot of different areas when it comes to healthcare. But the pharmacies and the pharmacists, especially in rural, so our 3 pharmacies are all considered rural. 2 of them are in a little larger town, and 1 is in a much smaller town. But we develop that rapport with our patients. They tend to, they come to trust you. They trust your judgment. They want to know, and they want their input. And as we expand scope of practice, and that's the area where Utah needs to work on, is allowing pharmacists to be considered provider status so that we can bill insurance on a lot of these things, and also advance the scope of practice to allow for some other things. It's a balance, and it is a balance in Utah to make sure that we're having that right balance, especially between the medical profession and the pharmacy profession. And up to this point, we've done a nice job with that, and want to continue to do that. I don't ever want to see a situation where one profession feels like they're being slighted for the other profession. But thanks for having me on today. I'm certainly open to any questions, and I certainly have, like I said, I really appreciated listening to Emily and Stephanie and Senator Hayward in their presentations. Sydney, I'll turn it back to you.
There we go. Thanks, Shannon, for unmuting me. Thank you, Senator Vickers. It was so wonderful to hear your perspective. Thank you so much for sharing. We have just a couple minutes for Q&A. So if you have some questions, please feel free to put them in the chat box. As a reminder, the webinar is being recorded. It will be made available to participants. I'm going to kick it off to Senator Steiner, Hayward, and Senator Vickers. So if a state, and Senator Vickers, you kind of touched on this already, if a state wanted to revisit their pharmacist scope of practice laws or regulations, where should they start? Who needs to be at the table to kick off those conversations?
Senator Hayward, do you want to go or do you want me to go?
Go ahead, Senator Vickers.
Okay, thanks. Well, and each state can be a little different with their pharmacy, their board of pharmacy. For example, ours is not a regulating board; it's a recommending board. But particularly the board of pharmacy works directly with our Department of Public Licensing, so they kind of pretty well follow. So that you need to have that that group. You need to have your state pharmacy organizations, but then also you really need to involve all of your state medical practices as well. And they usually have medical boards that you can interact with. We're actually looking at a rewrite of the Pharmacy Practice Act, and that's going to involve a lot of stakeholders. But I would think that that's where you'd most likely want to start. Senator Hayward, if you have any thoughts on that?
Thanks. I think the only thing that I would add to those really good suggestions, in Oregon, our situation is different. Our Board of Pharmacy is the licensing authority for pharmacists and the regulatory authority. So the links that I put up are all on the Board of Pharmacy website, and they're the protocols that are outlined by our Board of Pharmacy. But the other groups that I would encourage bringing to the table are, I'm guessing that in Utah, for example, Senator Vickers, you have an association of independent pharmacists. I'm getting a fair amount of feedback. Is anybody else? Okay, I think it's stopped now. You know, so you want to bring in the independent pharmacists, and you want to bring in representatives of the big chain pharmacies, including the grocery chains, where a lot of pharmacies are located, because you have to have some confidence that pharmacists are actually going to be interested in taking on whatever role this that you're asking them to do. And if you don't have that confidence and you don't have them at the table, you can make mistakes in the legislation that have unintended consequences. It's been really helpful for us to work closely with both the independent pharmacy groups and the chain pharmacies to be sure that we do all of these things right.
Yeah, I would agree with that. In Utah, we have an organization that represents pretty much the independents, and we have one that represents hospital pharmacy, and then there's one that represents chain pharmacy.
Great, thank you all. I want to get to this question quickly before we wrap up. With the HHS federal rule to administer vaccines nationally, what other policy considerations are there for incorporating pharmacists into COVID-19 vaccine efforts?
So let me just take that quickly. Our pharmacy board looked into that and found that, and you just really need to review your statutes to make sure that that's allowing, whether you're set up with collaborative practice or however you're set up. But our Board of Pharmacy reviewed ours and found that they need to do some tweaking. They were able to do that through rulemaking without statute change. So I would go directly to your Board of Pharmacy.
And we have, just to add before our colleagues from North Carolina chime in, we have representatives from the Board of Pharmacy on our sub-team, if you will, of our overall COVID-19 statewide management plan. In the vaccine subgroup, we have pharmacists or representatives from the Board of Pharmacy there for exactly the reasons that Senator Vickers outlined, because it is important to be sure that we don't need statutory change or any other rulemaking changes. In Oregon, we probably don't, because our scope for pharmacists is so big about immunizations in particular, but you know, if they see it, they will be on it. Any problems, they'll fix them.
Great. All right. I think we are at time. So I really just want to say thank you to our speakers, participants. Thank you so much for your participation today. We have some resources that you can explore at your leisure. I do want to highlight NCSL's Scope of Practice Policy website, and we track pharmacists' scope of practice legislation and include 50 state maps on specific policy topics, including prescribing contraceptive and tobacco cessation aids. I do want to highlight our upcoming webinars. Again, this is the second webinar in the NCSL Public Health webinar series. We have a total of 7 more webinars lined up over the course of the next few weeks on a variety of topics, including maternal mortality, suicide prevention, the distribution and allocation of the COVID-19 vaccine, and more. So for a complete schedule and the registration details, you can follow the link on this slide. Again, thank you so much. My contact information is on the slide. Please feel free to follow up with me with any additional questions. We would also like to extend a final thank you to our presenters. We greatly appreciate all of the expertise each of you were able to provide. And again, I'd like to thank the Health Resources and Services Administration for their support of this webinar. Thanks again to our attendees for participating in today's webinar. And as a reminder, the recording and presentation slides will be available on NCSL's website within a week. Have a great rest of your day. Thank you so much.